Hello, everyone. This is the New York City Department of Health and Mental Hygiene's update on COVID-19 for New York City healthcare providers. Thank you for joining today's call. Please note that you have been placed in listen-only mode. If you have questions during the presentation, please submit them via the Q&A portion of the WebEx, and we will address them as time allows. Joining us to present today is Dr. Margariti Ray, Critical Care Planning Lead for Healthcare System Support for the agency's outbreak response. And today's spotlight presentation will be brought to you by a few other colleagues from the Health Department and will focus on increasing COVID-19 testing in New York City communities through hyperlocal response. We thank Aaron Belay and Lou Rivera for joining us for that. And we will also be giving you a brief overview of our newly updated data page with Dr. Corinne Thompson. So with that, I will pass it off to Dr. Ray.
Thank you, Allie, and welcome back, everyone. Can you advance the slide, please? So as we announced last week, we are now able to provide CME accreditation through the New York City Health and Hospitals. I know this is exciting for me as I often struggle to document all of my CME requirements. So please stay tuned at the end where we'll give you the detailed information on how to retrieve that CME. Also, just as a reminder, these slides and a recording of this presentation will be posted to our provider website shortly after the presentation. Advance the slide, please. So our overview for today is, as usual, we will have a brief update on where we are now. Then I'll give you a couple of clinical and other updates on what's going on with COVID-19, especially with a focus on testing. Then it's very exciting. We are going to talk about the implementation of a new place-based, what we call hyperlocal approach. And we have our special guest stars, Aaron Belisle and Lou Rivera, for that. And then at the end, we will have Dr. Thompson back for some updates on some really exciting new data that we have available for you publicly on our website. And then, of course, you know, put your questions into the Q&A box. If we have time to answer questions verbally at the end, we will do that. Otherwise, we'll try to answer your questions in real time during the course of the webinar. And can you please advance the slide, please? All right, and can you advance again? Thank you. So this is a map of cumulative cases worldwide from Johns Hopkins University. At this point, we have over 22 million cases and almost 800 deaths due to COVID-19. In the US, cases are still increasing with over 5 million cases and 177,000 deaths. Also, you know, there is some hope on the horizon. Vaccine candidates are in various stages of development. Moderna, NIH, and AstraZeneca, Oxford University vaccines are already in stage 3 trials. And of course, we are continuing to monitor indicators of viral circulation in New York City. And as we've discussed a couple times on the webinar, these indicators help us really nimbly respond in terms of the policy approaches to COVID-19 and what we will reopen and what we will close in New York City. We'll give you a little bit as we proceed on the local risk in New York City. But again, stay tuned at the end for Dr. Thompson's presentation for really detailed and in-depth analysis, or where you can get the data and do your own analysis of that of the local risk in New York City. And can you advance the slide, please? So this is the U.S. So as you can see, you know, worldwide cases are increasing in many countries in the world. Unfortunately, the U.S. at this point is one of them. So this image of the United States looks at cumulative cases. So this is not necessarily the recent uptick, but all of the cases, you know, in 2020 of COVID-19 in the United States. And you can see that, given the experience in the Northeast, that the Northeast is still lighting up on the cumulative cases, but you can also see that, some of the other circles in areas like Florida, for example, are getting bigger. You can look at Arizona, California, and they're actually approaching the level of the Northeast. And so that reflects that there is continued transmission, even though right now our transmission is low in New York City. And can you advance the slide, please? So now for some news and updates. So one of the very exciting pieces of news is that the city has introduced free rapid COVID-19 virus testing that is available at multiple COVID Express sites, which have opened recently in the Bronx, Brooklyn, Queens, and Manhattan. So these rapid tests, the results will be given back within 24 hours. And then many of the other services usually provided at these facilities will still be available. So, so there are, it's a multifaceted approach to care. Now, the thing to remember about these tests, and if you refer your patients for these tests, is that it is by appointment only. And we have a link on the slides. Again, the slides will be available shortly after the webinar, but it's nyc.gov/health/COVID Express. And individuals can access this site to schedule a test and also create a MyChart account, because results will be available through MyChart. These tests are, these testing sites have just opened at 8 places around New York City. There will be a short period of closure starting August 31st, during which there will be a focus on testing DOE staff, Department of Education, around school reopening, but the sites will reopen to the general public shortly after that. And can you advance the slides, please? So as we talk about these rapid tests, and I'll give you a little bit of detail on how to interpret the rapid tests in a moment. This is just a reminder that New York State requires reporting of all COVID-19 test results. So that includes the point of care tests, that is the rapid tests, as well as the traditional PCR tests that you're used to. And that reporting happens through the electronic laboratory reporting system, or ECLAIRS. And positive results, of course, must be reported immediately. However, even the negative results have to be submitted to ECLAIRS at a minimum of 4 times a day. And the reason for this is that timely reporting allows us, really facilitates case investigation and contact tracing, which, as you know, is instrumental at this point in the suppression of COVID-19 and, in our management of the overall city burden of COVID-19, as we, as we think about and as we see second waves happening in other places in the world. We have a link here for New York State Department of Health reporting guidance. And then if you have any technical questions about reporting in the ECLAIRS system, you can call 866-325-7743 or use the email that's listed on the slides with any, and that's for any technical questions. Can you advance the slide, please? Another important piece of information that we are hearing from communities and from employers is that several employers are requiring any COVID-19 confirmed cases to provide a negative test in order to work. And so this is not an appropriate criterion. for returning to work, because as we've discussed on in this forum before, the detection of viral RNA by the PCR test does not necessarily indicate that a person is infectious. And often we see viral RNA persisting long after persons have recovered, even weeks and months after they've recovered from COVID and are not infectious anymore. And so, please reference the guidance on our website about when to discontinue isolation. And for most people, that the period of isolation that is indicated is 10 days and 24 hours free of fever. Of course, for persons who are severely ill or whose symptoms are not improving, and in a couple of other cases, that general guidance is not necessarily applicable, but we have a link here and we can copy and paste it in the chat with specific provider quarantine precaution guidance. For anyone, for general employees, please, if you are writing a sick note or a return to work letter, please include specifically that a negative test is not an appropriate return to work criterion. We actually have a template return to work note, which again is available, and then we can copy and paste that link and put that in the chat as well. Overall, in this return to work guidance, I do want to clarify that there are some specific exceptions, which include nursing home healthcare personnel and long-term care facility healthcare personnel, where there are regulations for those specific providers about testing and return to work. And again, please reference our guidance documents for the details of that test. Can you please advance the slide? And so the antigen tests for SARS-CoV-2, and I'll just refresh everyone's memory that when we say the antigen tests, we are talking about the rapid tests or the point of care tests. And these tests are generally less sensitive than RT-PCR. So PCR, as a reminder, is the viral RNA test, and it actually looks for the genetic material of the virus. This is the gold standard. The antigen tests or rapid tests or point of care tests look for are looking for a specific protein component of the virus. And practically what this means that in some symptomatic patients, that the level of that protein may drop below the limit of detection when an RNA test would actually still be positive. And so so if you have a rapid PCR test that is negative, it requires confirmation with an additional PCR test. And this is especially important if the result is inconsistent with the clinical context. For example, a person who develops symptoms or is not recovering or has, shortness of breath or another classic COVID symptom, and they still have a negative rapid point of care test. Now, the specificity, we just talked about sensitivity, but the specificity of the rapid antigen tests is generally as high as the PCR tests. So that means if a protein is detected, the person probably does have infection with SARS-CoV-2, and false positive results are unlikely. There's a lot of details about this on the CDC website on the antigen test guidelines, and again, that link is in the slides below. Can you advance the slide, please? And now I'm going to hand off the presentation to my colleagues, Erin Belisle and Lou Rivera. This is a really exciting new concept in emergency response. It's an application of what we call a whole community approach, and it also really is like a coming to reality or a fruition of what we call place-based approach. And they're going to talk about, what this hyper-local response, which involves understanding community assets and cooperation with the community, as well as a targeting of our resources to focus on combating the ongoing impacts of structural inequities. And now I'll give it to my two colleagues to talk about how we implemented this new framework into neighborhoods.
Thanks, Didi. It's Aaron. You can hear me, right?
Yes, we can hear you.
Good. I mean, I could spend a long time talking to myself. I just wanted to make sure. Hi, everyone. I'm Aaron Belisle. I'm the Director of Emergency Planning in the Health Department's Office of Emergency Preparedness and Response. And during emergencies like COVID-19, I do a little bit of everything, including help coordinating this project that we're presenting on. Lou, are you there? Do you want to just jump in and introduce yourself before we get started?
Hi, can everyone hear me?
I can hear you, Lou.
All right, my name's Lou Rivera. During my day-to-day role, I'm the Director of Community Engagement and Response for the Office of Emergency Preparedness and Response. And then in this most recent activation role, I was the lead for community partner engagements for this hyper-local neighborhood testing initiative that we'll be talking about today. So really working on the ground at the testing sites with community partners to bring out people from the community to come out and get tested.
Thanks, Lou. Can we go to next slide? So what is a hyper-local response? Well, it's, this picture here is one of the mobile testing sites that was opened in Sunset Park, Brooklyn, in support of the pop-up site that we opened. And this has been a recent effort by the Health Department to expand testing resources in neighborhoods to increase the overall testing rates in those neighborhoods. And so we've done this in 2 neighborhoods so far. We did it in a neighborhood in the Bronx and also in Sunset Park, Brooklyn, and we will be talking about them in turn once we go through the overall effort. Can we go to the next slide? So how do we identify neighborhoods for this type of action? Well, we center it around a given zip code, and these are the types of things that we're looking at in terms of determining which neighborhoods need this. First is the systemic inequalities in that neighborhood. Then there's if we have a surveillance signal indicating that there's been recent activity with COVID-19, elevated percent positivity in terms of how this neighborhood relates to the averages in the city. Then if there's a high case rate with a low testing rate. So obviously the idea that, if you have a high number of cases but a relatively low number of people getting tests, something's going on here. And we're going to dig into each of these details. So next slide. So long-standing inequalities, or inequities. So we're looking at households at or below 200% of the federal poverty level. We're looking at those that receive public assistance, such as food stamps or SNAP, households that have more than 1 occupant per room, and also residents without health insurance coverage. And so what we know from national studies, in particular for COVID-19, but just in general, that these are indicators that means that the population is more likely to have underlying health conditions, and that these are people who are more likely at risk at COVID-19, both in contracting it and also having negative outcomes. So all of this is put into balance and consideration of which zip codes we want to do this. Next slide. And we also want to consider the neighborhoods that have a high burden of COVID-19. And so what does that mean? Well, it's neighborhoods that have a high number of cases, hospitalizations, death rate, and also the percent positivity. And this is all relative to the other neighborhoods in the city. They are ranked in order, and then based on the number of weeks, they're among the hardest hit neighborhoods in the city. And this data goes back to March. Next slide. So again, as I mentioned, this is about low testing with high positivity. So the testing rate and percent positivity is considered the rate per 100,000 people among residents residing in non-congregate settings. I just want to underline that it's non-congregate settings. And then we also look to see what recent transmission has been found in this neighborhood by finding laboratory confirmed cases, and also people who reported symptoms, and looking really within the past 4 weeks. There was really an effort here to find the neighborhoods that are seeing the recent action and recent concern. Next slide. So with all these things are considered and balanced together to identify neighborhoods, zip codes that could benefit from increased focus upon both testing and also care given to the residents. And so the strategy that we came up with and that we implemented in both the Bronx, the Tremont section of the Bronx and Sunset Park, Brooklyn, is to set up and operate community-informed point-of-care rapid testing in these neighborhoods, and then providing immediate access to support services for those who test positive, and then using community feedback to inform the placement of that rapid testing site where it needs to be, along with the mobile testing resources, and then conducting community partner engagement to educate people and involve the community in the testing. And then again, we're going to go through this all in turn. And next slide. And I think that this is where I hand it off to Lou, who will begin talking about that community engagement. Lou?
All right, thank you. So I think, Aaron really touched upon how we began looking to engage with community partners. And there was a lot of what we call pre-engagement work that happened. So really taking a look at the community to see whether or not it met certain metrics. In addition to pre-engagement, and when we worked with our colleagues, both in the Center for Health Equity, and then our community partner engagement unit, to determine which partners were in the neighborhood, which partners could really successfully support these testing sites that were going to be coming to their communities, and then really looking to see what kind of how these community partners, whether they're CBOs or houses of worship or healthcare facilities, how they could help to partner and amplify the testing efforts that we would be bringing to each of the zip codes that we were in. And in this particular slide, you can just get a sense on the demographics in the Sunset Park community, 11220, and just what we were looking to hopefully achieve once we got in there to test. Some of the metrics we look at overall for this initiative was communities that have high positivity rates, in addition to having low testing rates, in addition potentially to having low infrastructure or not too many options for testing. So these are some of the metrics that we would look at when we would go into these communities and begin really working with partners there and really planning out how we were gonna have people come out to get tested. So we can go to the next slide, please. So really, what we wanted to do throughout this whole initiative, and Aaron spoke a little bit about this already, is just really engaging with the community partners that were out there, with the anchor institutions, with the ones that have all of the knowledge about who that community is and how that community functions and the needs of that community. We wanted to make sure we weren't just going in there as the health department and saying, this is what we're doing, but really actively engaging, as Dr. Didi meant, I call it Dr. Didi, but our colleague Didi mentioned earlier, really using the whole community approach and bringing providers from different fields that work in the neighborhood together with the health department to really determine how to best offer these services. And then also really taking into account any feedback while we were out at the site that could help improve the processes overall. And also, we wanted to make sure that we were connecting to existing relationships. So this is where it became really helpful to pull everyone in who was doing any type of public facing work or community engagement work and saying, this is what we're planning to do. We're going into the Sunset Park community, the Crotona, East Tremont section of the Bronx community, and we understand that you have relationships there already with different providers and CBOs, and we'd like to partner with you to make sure that they understand everything that we're trying to achieve here with this initiative. And so we brought in a lot of those key players from the health department who already had those relationships built. And some of those included our community engagement and response unit, our Center for Health Equity and Wellness, and many other people from across the agency to help inform how we were going to outreach and begin doing this. And then lastly, we just wanted to address the needs and the knowledge and the inequities that exist, right? We wanted to make sure that everyone who needed to be at the table was at the table. And a lot of this went into pre-engagement, and it certainly fed into when we were actually doing the operations on site at both zip codes. Next slide, please. So really, when we began, after we did all the pre-engagement work, and now we're actually at the operations, really, this is where we began to see those relationships that we had, those pre-existing relationships that we had in place as the health department, really come to benefit this whole initiative. We really worked with our community partners to do canvassing to local businesses and congregations. They partnered with us in doing door knocking, and this was our strategy in doing community engagement. Some of this we actually had planned before we got into the community, and I'll talk a little bit about some of the things that changed as a result of being in the community doing this work. But some of the strategies consisted of doing canvassing in local businesses, canvassing to local businesses and congregations and community-based organizations, and also some healthcare groups and or organizations to disseminate materials specific to the testing that was going on in the community and specific to COVID-19. We did a lot of information and listening sessions. So we actually had partners in the 11220 zip code and 10457 host listening sessions for their community members to understand why we were there and why it was important to get tested and the type of testing services we would be offering. We partnered with local media to get the word out. We also did emails to partners, and we did neighborhood flyering. The one interesting piece in 11220 that came about as a result of us really wanting to, gain further access into the community and make sure that they were coming out to get tested was that we began to do door knocking with community members. I call this sort of the old-fashioned outreach that used to happen, at least when I started doing outreach many moons ago, where you actually went out and you did door knocking and you didn't have social media apps to get the word out. And we really found that to be effective in the 11220 zip code, Sunset Park, and really getting people to come out and get tested. Additionally, we also hired interpreters to come out with us that spoke Mandarin and Chinese and could actually help to engage with the Asian Pacific Islander community in Sunset Park to help them understand what we were trying to do and to get them to get tested as well. So just, in this bullet here where it says partner calls and interviews to understand key issues in the neighborhood. So we did a lot of this while we were actually testing in the community to get a better understanding and to take that feedback and use it to hone our community engagement techniques. So as we began to talk with community partners, some of the things that they raised to us was just testing concerns in general. Sometimes some communities just are not very trusting of government, and rightfully so. And so really trying to come up with the best messaging for communities that have a distrust of government to actually come out to the health department's testing site. And a lot of that consisted of community partners actually sort of serving as ambassadors to the community to get the word out on behalf of the health department. Some of the other things that came up for us was physical distancing. And we wanted to make sure that we addressed that. So we had a lot of social distancing on site at our test site. And we took pictures, and we actually had some of the local news come out and see how things were going and take pictures so that they can inform the community that we did take physical distancing and social distancing issues seriously, and we ensured that that was happening on site. And then also, difficulties with isolating and quarantine and face covering. So we really worked to partner with the Chinese Planning Council in Sunset Park to offer resource navigation services that would help to address some of the concerns around isolating and quarantine and, making sure that they understood the importance of face coverings and hand hygiene. And things like that. So this was really a huge public-private initiative. And to me, it's something that I feel very thankful to be a part of, because it was something that actually really, really benefited the community and had the support of so many different community partners there to provide these testing services. Next slide, please. So, additionally, in some of that pre-engagement activity that we spoke about, we really worked with community partners to get their sense on potential testing sites and spots that would work. We wanted to make sure that we were, intentionally choosing these testing sites so that people would come out and access them and that they would be trusted by the community. So we did a lot of working with community partners to identify testing sites across 11220, as well as in the Bronx. We worked to ensure that we had the language access skills in place to engage with the community. And then we also, as I mentioned, did a lot of messaging around fear of exposure, social distancing. We also made sure to have a lot of discussion around the importance that your immigration status is not needed to take this test, that this will not be something that will be impact public charge, and that this was a free service to the community. So we had to do, there was multiple times where we've had to message all of this, either through those listening sessions or through social media or through traditional media, to ensure that the community understood and knew that they can come out and get tested without any trepidation. Next slide, please.
This is back to me, Lou.
No problem.
So
Sorry.
So we're going to talk about the pop-up sites itself, and just to add to something that Lou said, that one of the key things with the community feedback was essential is, again, just identifying where you actually wanted to put the site. I mean, we're within a given zip code. The neighborhoods aren't that big, but even a site that is only 5 minutes away, it sometimes seems like a world away, and we get feedback, oh no, we don't go there, and so, that's one of the essential pieces on this. So this photo here is the pop-up site that we opened in Sunset Park, Brooklyn, and so, Lou already went through this, and we talked about how we select the neighborhood, but we all, some of the good stuff about pop-up sites is that just recognizing that these are temporary spaces, that we set them up in the community, in non-healthcare settings, with the idea that testing is already available in a healthcare setting, and that we're appealing to people who, for the reasons Lou just mentioned, might be hesitant to interact with that. So we use a church in the Bronx, and we use a school in Sunset Park. And then it's designed for quick flow in and out, being mindful of people's time, and also making sure that we maintain physical distancing. Next slide. So here's a photo of an Abbott ID Now testing machine. These are the point of care tests we use. The slide has a mistake. You review these slides so many times. It's actually not a PCR test. I actually don't know what type of test it is, but it's not a PCR test. I know that. It's a mistake for me to talk about.
Sorry, it's an antigen or molecular test. So this is the same test that we were discussing earlier in the presentation. And so I think your presentation will reinforce what we said above.
Yes, thank you. But anyway, it's a point of care test, this idea that allows for same day test results. The machine can run a test within 15 minutes. And so, given lines and demands, if someone can go to one of our sites and get a result within, a few hours. Next slide. But because of the nature of these machines and their sensitivity, we have to do a confirmation or a reflex test, which means that 2 swabs were collected from each person. The first swab is for the point of care machine, and then the second we sent to our New York City Health Department Public Health Lab to do a confirmation test within 24 hours, and that is a PCR test. And so what we have found over the course of doing this, when we were in the Bronx for our first site, we did confirmation tests for everyone that we saw, but because there was concerns about false positives, false negatives, what we found from the results of the Bronx was that there were no false positives. All the positives were then confirmed by the PCR test done by our lab, but there actually was a significant number of false negatives. So the ability for us to do that test and to get results back to people within 24 hours was really powerful. And especially with commercial labs, having a median about 4 days return, it's even higher if you use, an urgent care site. So, this idea that someone who is going to one of our pop-up sites knows whether or not they're COVID-19 positive or negative within 24 hours is pretty positive. Next slide, please. And then the whole point of all this is the good public health of it all is to connect people to services immediately if they're positive, and that's called resource navigation, and the people who do this are called resource navigators. So again, when we were operating these sites, people would wait for the results, and that if the machine identified them as a positive, they immediately met with a resource navigator who discussed the resource options that were available to them and really could have some long conversations with them to weigh their options, bring in their families into this. It was very similar to a case manager type role because, these are very important decisions that people have to make. There's a lot of detail there. And so these resource navigators would spend a lot of time helping people work through that and connect them to various services that the city has available. For example, like, connecting to hotels that we have and connect to the trace team that's working. So this is both for the positives that were on site for the point of care machines, but also for the PCR test if we identified positives through the reflex test. And all the people who tested positive were offered services to the city. That's a key thing because testing alone without the connection to services or understanding what the test means and what you can do about it is not as helpful. Next slide. And we should also recognize, and I already mentioned this a little bit, but we should recognize the fact that these pop-up sites are really providing unique services. They were popular. We tested over 300 people per day on average. We think that the popularity is likely due to the inability to get rapid test results anywhere in the city. Actually, we saw people really, we're trying to target, we're going to have some slides on this later, but we're targeting testing within these neighborhoods, but we actually saw people throughout the city, throughout the state, other states come to our site because, again, that rapid and quick turnaround. We saw that some people were required to have tests done for travel and schools, and some clients, Didi mentioned this in the slides earlier, some clients informed that their testing was being required as a condition of employment. And I would say that to some extent, some of this were maybe their employers were not necessarily requiring the test for legitimate reasons, but that we're serving populations that don't necessarily have the ability to push back on that requirement. Next slide. And Lou, I believe this is you to talk about the challenges in targeting the residents in the zip code.
Hi, yeah. So what we saw in regards to some of the challenges in the zip code, even before getting into the zip code, when we began meeting with the community partners to get a sense on how we should begin engaging in 11220 in Sunset Park, many of them told us about the distrust of government in the community, especially for those communities that have a significant portion of potentially, immigrant populations and or undocumented. So when we actually got into the community, we saw that firsthand. We began to see that almost immediately. And we really had to look at our strategy to think about how we were going to engage with the community. And so that, as a result of some of that, as I mentioned earlier, we were able to get, we had to get in interpreters that can go out and work with our outreach and engagement staff to go out and speak to the communities that didn't necessarily speak English or didn't have a strong proficiency of English. And what we noticed, it was really interesting to bring interpreters out with you to do outreach. They actually, at the end of this whole project, winded up being outreach workers. It was amazing to kind of see them morph into that role as they got comfortable with talking about this project. And then also, like, they really bought into bringing people from the community out to get tested. So that was interesting. That was one of the challenges we saw. Another thing another challenge we had was having people. So Sunset Park is not huge, but there's this clear divide, when you're there about what section is part of the Asian community, what section is part of the Latino community, and then where everyone else falls within those two communities, the Bangladeshi community and things like that. So we really had to look at how the sites were going to be set up in Sunset Park, understanding that our rapid test site was actually on 60th Street between 3rd and 4th Avenue. So right there, we're starting off with our rapid test site not being close to the Asian community. And so as we began to look at other sites that can be set up for mobile test sites, we had to ensure that that those mobile test sites were in and around the Asian community or places that they would frequent to get tested. So really having a clear understanding of what that looked like and how people who lived in Sunset Park in 11220 actually went about their daily lives and interacted with their community. So we had to understand that quite clearly. And I think also one of the things was that it was hard to, once the word got out about this, I think Aaron mentioned where people were coming from. It was really hard to limit testing to people in the 11220 zip code. We didn't want to require proof of address or ID because that would potentially deter a lot of people from the community coming out to get tested. And then also there were a lot of reasons why they wanted those tests. So we couldn't just say, no, you couldn't come in because you were from 11220. One way we really remedied that was to have 2 days. We extended testing operations for 2 days, but we did no we didn't do any sort of advertisement of it. And then we just worked very closely with our community partners to put a sort of an appointment system in place where they were actually able to get appointments and then bring people in from the community directly to get tested. And that's also when we began to see a big response from community coming in saying we wanted to get tested, but those long lines deterred us or made us unsure of whether or not we wanted to wait. So once we put the appointment system in place, we were actually able to get a lot of people from the community to come out and get tested. So those were some of the challenges. I think also language access was a challenge for us as well. But definitely as we began to tweak those outreach strategies, we began to see increase from community members coming out to get tested. Next slide, please. So really, I mean, this slide really just reiterates a lot of what we did and a lot of what we spoke about already, just making sure that we were in constant communication with our community partners, taking all their feedback into account, and then trying to tweak our outreach strategies and our operational strategies to reflect that feedback that we got from community partners. As I mentioned, we put a ticket system with appointment times in place that really helped. And those tickets were actually dispersed to the community partners. So the community partners had the flexibility to reach out to their clients and or community members that they work with and get them, appointments that they can just walk right in and get tested and not have to wait online. And then, as I mentioned earlier, our door-to-door outreach. I was a little skeptical of that at first because I understood the intensity of that. But it really did work. It really did work in getting people from the community to come out and get tested. And I think I think just the last bullet was just really about, those 2 days that we did unannounced, which was just dedicated to 11220. And the community really did come out for it. Next slide, please. I mentioned this earlier about the mobile testing vans. So, we made sure that the mobile testing vans were in communities that were, as a result of putting our rapid test site or same day test site in one part of Sunset Park, we made sure that our mobile vans were situated in other parts of Sunset Park so that we had a wide reach within the community when it came to testing. And our community partners helped us really locate where those testing sites should be. And the mobile van test sites, they didn't offer rapid testing or same day test results. So what they offered was the PCR swab for RT-PCR testing. So basically they got their results, I think, within three to 5 days at the testing sites that we partnered with a group called CORE for that. Next slide, please.
This is me, Lou. So, and I just want to Lou already went through this, but it's just interesting, in terms of understanding your neighborhoods, you really do have to understand each individual neighborhood because we saw variations between the two. So, for example, the ticketing system was super successful in Sunset Park, but the feedback that we got from the Bronx community was that the population didn't respond well to ticketing and preferred to wait in line. So, hey, it varies, but you have to do the outreach to know those differences and understand how to really meet the needs. So let's talk about providers in the community because this is really the key to connect people to care. And so, we're aware that our pop-up sites and the mobile vans are only temporary services, and we don't want to feel like residents to feel that we're leaving them behind. So throughout all this, we did outreach in making sure that people were aware of the providers that are in those communities and the resources that are available to them. Next slide. And so what we did, getting the message out, so identifying providers in the area to ensure the connections to care and the continuity for additional testing, follow-up. So emails were sent out. We conducted phone calls with several clinical partners, primary care settings, pharmacies to share the testing information, as well as to talk to them about their capacity to accept new patients or provide services to low-income or uninsured people once they interacted with us. Next slide. And so here you see the numbers of the reach. These are the numbers of emails and connections we made with the pharmacies and the small practices and the primary care. And for the Sunset Park, which was the second neighborhood, there was a little bit more give and take with the providers. And what we saw was that there was a lack of resources for non-English speakers, mostly around communication. Just the providers talked about the lack of testing kits, fear of exposure amongst staff, and this idea that patients call all the time to get test results, especially if, the test results take a while to come through. And as you could see, confusion among patients about exposure at testing sites, fear of leaving their house, the costs and the insurance issues, and also the wait time. So those are some of the themes that we saw in our work. Next slide. So these next couple of slides just highlight what we saw in the 10457 Bronx zip code. This is the Tremont, Claremont section of the Bronx. So over 7,400 people were tested by providers in the pop-up locations in the 2 weeks that we were operating, and that includes all the providers and messaging. So we saw a clear increase of testing overall in this zip code, which is really what we were looking to do. And the health department itself at our pop-up site tested 3,400 people over that. About 200 people were identified as positive for COVID-19 through that. And again, you know, these increases really showed not only in the 10457 zip code, but even the surrounding Bronx zip codes just showed just an incredible desire and need for testing within the borough of the Bronx. And I really think that the pop-up site was success because of our community members, strong word of mouth. The fact that we situated our pop-up site in a church site and that they're a trusted member of the community, I think really helped people come out and get tested, because as Lou mentioned, the not uncommon distrust of government. Next slide. And here are some of the highlights for our 11220 zip code, Sunset Park. So over 5,100 people were tested by providers or the health department in this zip code. 4,500 by the health department itself, which is even higher numbers, just incredible demand. We saw a relatively high percent positivity around these people based on the average of the city, and then connecting to trace investigators to identify household members as most common exposures. I'm not a scientist. I can't say why the higher percent positivity, but I think it shows the demand and the people perhaps who were most concerned about their status coming out to get tested. And it really showed the need for targeted outreach among the Asian and Pacific Islander community. Lou touched upon this a bit. There's a lot of testing myths and misconceptions around them. In this community. There's language issues. A lot of the Asian and Pacific Islander communities actually get tests sent to them in the home from overseas, and I don't know if these tests are valid or good or anything. So a lot of that outreach was to say, well, why do we need to come out to this test site? I can get tested in the home. So a lot of it is education around that. Next slide. And I believe this is the last slide. So our overall observations, I think you've already heard it. There's a high demand for testing with timely results. I mean, that's a given. And then, as Lou pointed out, placing testing in a neighborhood alone does not increase the testing rate. They have to be tailored to the needs of the community, and you need focused and sustained community outreach, both with community partners, CBOs, and also the providers in that community to get local turnout. Because we were communicating with the providers in the community, they would have patients come in and say, well, I need a COVID-19 test. I'm traveling within 2 days. I need this test, and they would refer them to our site because we were able to provide that. So I don't know if we have time for questions, but I'll just pass off the baton. Back to you, Dee Dee.
Great. Now, I just want to welcome Dr. Thompson back. She's the lead of our Epi Data Unit, and she'll be giving us another update on the local data for New York City, as well as some really exciting new updates to public data that we're providing. Welcome, Dr. Thompson.
There you go. Hello, everybody. Thank you again for tuning in. I've been on a couple times, so hello again if you remember me. So I just wanted to go over some really exciting updates to our webpage. I've been telling you they've been coming for months, and finally they are approved and arrived. So just a quick EPI update generally before we get into the new stuff. We've been holding steady at about 250 to 300 newly diagnosed cases per day. That has actually been pretty consistent for the last 2.5 months or so citywide. Our number of hospitalizations is also holding steady, and our number of deaths is declining slightly, so we're now at about less than 10 confirmed deaths every day by date of death, which is very exciting. We are, of course, monitoring for a second wave resurgence, and we have some new milestones here that will hopefully help to inform the public and people who come to this website about whether or not we're seeing a second wave. But just to highlight some new elements of our webpage here, that will also relate to whether there's a second wave. So just on the main page here, you can see there's
new tabs up here, we have main, recent, and testing. So on the main page, we've modified how our the general epi curve looks overall. So we have now the 7-day average where you can scroll over and see with the last 7 days, the number of new cases. Sorry. I believe the most exciting stuff is on the recent and testing. So the recent page, this is data from the last 4 weeks. So we understand that people are not necessarily interested in overall numbers at this point because the epidemic is so old now in New York City. So we have worked very hard to put recent information up. So this is citywide, the most recent 4 weeks with data ending through August 15th here. So you can see decline over time, the weekly cases and also weekly deaths. And you can see the most recent weekly change as well. They're both in the negative, which is very good news. We also have recent case data by zip code. So you can come here and see case rates, case counts, death rates, and death counts. And again, you can hover over and see the recent value. So as Aaron and Lou were talking about, Sunset Park, you can see is a darker purple, in part because of all of the cases that they were able to identify, which is great. Also, just want to highlight the table here. We have now each zip code has its own row, and you can see trends over time by zip code, and then also this recent change. So the previous 2 weeks compared to the preceding 2 weeks. So if this is positive, it means it's increasing, and if it's negative, it means it is decreasing. So if you're interested, you can search for your neighborhood of choice and see what's happening in your own neighborhood. Also of interest recently is percent positivity. So this is a map of the last 4 weeks of percent positivity. The darker the color, the higher the percent positive. And again, you can scroll over and see the value there. The percent positive for Sunset Park is 3.12%. Also looking at test rate, which obviously influences percent positivity. And this information is available in tabular format as well. I know we don't have a ton of time left, but I also just want to show some exciting serology data. So we now have not only PCR-based data here shown number of people tested over time, but we also have antibody tests or serology information. So we have people over time who are tested. You can see it peaked in late May, early June, and then the number of people that are positive over time. And also you can check out percent positivity, and it has stabilized. It's about 20% of people who are being tested for antibodies are positive over the last several weeks. And then also just something of interest, this is a map of testing rate here. The darker the color, the higher the testing rate for antibodies, and also the percent of people who are tested who test positive for antibodies. Again, this isn't seroprevalence, so we can't say anything about the antibody level across New Yorkers as a whole, because the people who get tested are not representative of the whole of New York City. But still, it is interesting. It does match pretty closely with what we were seeing for PCR positivity, which lends some credence to what we're seeing here with serology data. And the last thing I'll say is, just so you know, you can always download this information for yourself. So we have a link here, download case data and technical notes on GitHub. If you have any questions about what we're presenting, we have a really large kind of data dictionary and explanation of where our data comes from and why. For example, the case counts might go down from Tuesday to Wednesday, or why the number of deaths may go down, or kind of other various data cleaning issues. And you can also download. So for this one, you can, if you're interested in the percent positivity by zip code, you can click on the recent folder and download for yourself the information by zip code. So we hope that that's helpful to you, and I'll be happy to take any questions. Thanks.
Thank you to Dr. Thompson. And we also have some slides with this information that will be included in the slides that will be posted to our website after this webinar, along with a recording of Dr. Thompson's review of the webpage as well. So we have maybe 1 minute left. I'm going to kick it back to Dr. Ray if there is 1 or 2 questions that you would like to address to the group.
Sure. So let's ask Aaron and Lou. We had a question about door knocking in the Sunset Park implementation of the hyperlocal response. And can you just speak a little bit about, fears about contracting COVID, either from the outreach itself or at the testing site, and what we did with our staff to ensure that they were safe?
Got you. So for the door knocking, I have to admit, I think I said to you guys earlier, I was a little bit skeptical when the recommendation was made to do, direct door knocking for so many different reasons. One, whether or not we had the staffing that can do that, safety for the staffing, whether or not residents would be amenable to that. And so we started off doing it a little slowly and tweaking, and then eventually we wind up doing door knocking towards the end for all of our outreach. But we really realized with the door knocking that the residents were open to it. They were very thankful that we were coming out to them and saying, hey, here's what we're doing. You can walk right in and get tested as a resident from 11220, and you will not have to wait on the line to get in. And so once we began communicating that to them, they started showing up to get tested and taking appointment cards from us to come in and get tested. We did a lot of work around safety in general for our staff and also for our community partners for them to understand how serious the health department was taking safety into account. And so for our staff, they had access to PPE when they were going out and engaging and doing outreach. And then in addition to that, our community partners that were on site also had access to the same PPE. As I mentioned earlier, we did some media blitzes with social media and traditional media, and we had them come take pictures of how we were implementing social distancing in and around the site. And we received a lot of positive feedback from people that were coming in to get tested, as well as from our community partners and from media about how our best practices specific to social distancing was really good and made people feel safe to come in and get tested and not have too many worries about, potentially getting contracting COVID as a result of coming to a COVID testing site. So there was a lot of work that needed to happen around that, especially education, I would say. And we also had a safety person on site the whole time we were there that could speak to safety issues and concerns that came up.
All right, thank you, Lou. And I think since we're over time, I'll just briefly address the another question that we've had a couple times. I know we've spoken about it a couple times in the presentation, but I just want to go over the different types of tests that we're offering. So in terms of the diagnostic tests for COVID, as in does a patient have COVID right now, we are offering two different tests. One of the tests is the test that you've heard about frequently up to this point, and that is the PCR test. The majority of so in general, these tests in New York City are offered as a nasal swab. They are considered the gold standard test. They take a couple of days to come back. And this is the test that you've encountered the whole time. So for this test, if you test positive, you're considered a positive. If you test negative, you're considered a negative. These are the tests that if patients require a negative COVID test to travel, for example, this is the test that is required. They're collected via nasopharyngeal swab. The other test that we spoke about, now there are several names for this test, is the rapid test. You might hear it called the antigen test. You might hear it called the point of care test. You might hear it called a molecular test. This tests for a protein rather than the genetic material of the virus. It's also collected through a nasal swab, but it's able to come back much faster. So in the testing sites you heard about in the hyperlocal initiative, it came back in less than an hour. I think within the new within the COVID Express labs, it's going to come back within a day. And these tests are very specific, meaning that if the test detects the protein, it is very, very likely that a person has COVID, and they likely do not need a confirmatory PCR test. However, if a patient is negative, that negative test, there can be COVID, there can be virus in the virus that is detectable by an RNA test, viral genetic material. However, and so a negative rapid antigen test does need a confirmatory PCR. And I think that I don't know, Dr. Foote, would you like to comment?
Hi, sorry, can you hear me?
Yeah.
Yeah. So the test that's being done is the Abbott ID Now at least the Quick site. Largely, those are the Abbott ID Nows, but some other platforms that are the Quick nucleic acid amplification test. Those are point of care, but they still have to be done at a CLIA certified lab or adjacent setup. So those are, yes, as Dr. Ray said, those are done, can be done anywhere between 15 minutes and about an hour, but the results can take a while longer to come back just due to the volume and getting all the results up into the system. So it's about 24 hours, to get the results uploaded for the Express lab. But there is also the antigen test, which is different than the molecular-based test, and that is one that can be done at the point of care at a clinic level if your facility has a CLIA waiver. And those are, because they're not molecular tests, they're still very specific, but not nearly as sensitive. And so those are not recommended to be done in asymptomatic patients for screening purposes. Those should only be used for patients with symptoms or high risk for, have a high potential to be asymptomatically infected due to a high risk exposure or something like that. And those should be certainly confirmed with a molecular-based test if you have a negative result, because of the sensitivity issues, especially if you have somebody that is a higher suspicion or a higher risk exposure. So I'm not sure if that answered the question, sorry.
I think that's good for this. And then I don't know if we want to I think we're going to sign up, but if you could just advance the slide to the information on CME. So yeah, please log on to the CME website to obtain your CME. And thank you so much for joining us.